Alrighty, welcome to the hypoglycemia updates that will be taking place in June 1st. It's not a lot of changes happening. It's more so introducing how we're going to be giving glucagon in the future due to supply issues. So with this here, we're going to just jump right in and do a quick review of E10 hypoglycemia. So we are going to make a few changes, especially when it comes to how we administer glucagon. So to access CareMap E10, we're going to use this CareMap if we have confirmed hypoglycemia as indicated at point of care glucose. In patients a year and older, we're going to look at 4 millimoles or less BGL, and in 72 hours up to 12 months is 3.3. So neonates can actually go lower than that, but for this one, we're going to go with 3.3. That's what's put forward by Shared Health. With this as well, we have to keep in mind that these numbers are not set in stone. It is definitely based on the patient and how they're presenting. Some patients may display signs of hypoglycemia, much higher blood sugars. So if your patient looks like a diabetic hypoglycemic patient, and their blood sugar is 5 or 6, and you're like, well, it's over 4, we're good, it's definitely patient permitted. So try to get a baseline of what the patient normally is if they do check their blood sugar regularly, because if the regular blood sugar is 12 or 13 and they're sitting at 5, for them, that might be hypoglycemia. The other thing we have to keep in mind is that even if a patient doesn't have a history of diabetes, we should be checking blood sugars anytime there's altered LOC on patients. We're not really sure why. Just because they're not diagnosed as diabetic doesn't mean they may not be diabetic, because we all have patients that just never see a doctor. So it might be that they are diabetic, they've just never been diagnosed as a diabetic. So we always want to have that level of suspicion with patients as well. Just kind of tying into that, if we do have like pediatric patients that have just been diagnosed with diabetes, or even adults for that matter, we may be looking at hypoglycemia based on medication. So maybe an accidental medication overdose. It may be that they're trying to play with their insulin levels because they've just switched from oral hypoglycemia to anti-hypoglycemics to insulin, things like that. So it might mess up their blood sugars as well. So they might have a learning curve with their dosing when patients are recently diagnosed with diabetes. So we may get sudden drops in patients that normally would be fine. So again, getting patient history, asking caregivers if there's any family, have they started new medications, have they been changing dosing? Because especially if it's an accidental insulin overdose, they took too much, they forgot to eat, we might look at having to do multiple more dosages of our hypoglycemic medications like glucagon, D10, all that stuff. We might have to do more than normal, which might involve a call to medical direction. So the other thing to keep in mind is that patients that do have long-term diabetes, it's not new to them. It's not a new thing. They may not have that, drowsy, lethargic, intoxicated look like some hypoglycemic patients may have. They just might go straight to lethargy, confusion, and just straight up seizing. They may not have that transgression into hypoglycemic level, decreased LOC. So it might just happen very suddenly for them. So when it comes to neonates, little ones, when we want to use the lancet on these patients, their little fingers, little toes may not be big enough to actually accommodate our lancets. So just as a little side note, if you're wanting to do a blood sugar on a neonate or just an infant, it's usually recommended to use the heel like it shows in the pictures here. It's just you squeeze the heel and you take your blood sample from there. That way we're not piercing right through their fingers or little toes. And the other thing to keep in mind with babies is that, it's going to be a little bit harder to diagnose, because with adults, if they're not talking properly, slurring their speech, stuff like that, we can ask. But with them, it may be more so they're very irritable, lethargic, they haven't been eating, they might be very tremulous, and those all could be all indicators for hypoglycemia. So again, anything if the parents are like the baby's not responding, they're very slow, they're usually more active, it's probably a good idea to check a blood sugar on these little ones. And this can also be a good indicator of oral intake. So when it comes to babies, ask about ins and outs. Are they peeing, pooping? Are they taking in fluids? Because with little ones, because they are breathing through their nose, if they have an upper respiratory infection, sometimes it can be very difficult for them to latch on for breastfeeding, bottle feeding. So they might actually have not only an infection going on, upper respiratory issues, but also be hypoglycemic because they are just not being able to eat because they're basically can't breathe while they're trying to feed. If there is evidence of starvation, though, that's very different. So be aware for child neglect or abuse with that as well. But again, just little ones, we're going to approach them a little bit differently, get a lot of questions, ask what's been going on with them and what's changed. So contraindications to the hypoglycemia care map is if you don't suspect hypoglycemia, we're just not going to access this care map. So the first thing we're going to look at our patients if we suspect hypoglycemia is the patient able to cooperate and swallow? So they're just kind of obtunded, they're kind of lethargic, they're still able to look at you, open their mouth, stuff like that. If they are, and we're just going to give them oral or buccal glucose as per M06.1. So with M06.1 glucose, again, indications pretty much the same as E10 care map. Confirmed hypoglycemia, suspected hypoglycemia. And again, if you're not suspecting hypoglycemia, we're not going to give this med, so there's no contraindications in that regard. So the dosing for here, so 17 years and up is 25 to 50 grams, 10 and up it's 10 to 17 years is 12.5 to 25, 1 year to 10 years it's 12.5 grams, and we give that orally. If there's really no other options for dealing with hypoglycemia at this point, and the patient is unable to chew, swallow, or has decreased LOC, if they're unable to protect their airway, right? So we want to prevent seizures from happening. We want to try and get some sugar in our patients. So if you're really out of options, you can put the patient on their side and apply glucose paste in the inside of the lower cheek. So in the picture I have here, there's gel and there's tabs. So for gels, that will work. Tabs, not so much, because sticking a tab in a patient's mouth and waiting for it to dissolve is probably not going to work too well for you. But if you have the gel, that would be ideal. And the big thing, of course, is always be worried about aspiration. So if you're worried about any choking hazards, just, again, put it in the dependent cheek that's laying closest, and then just always have suction ready just in case. And if you're worried about seizures, don't be putting your fingers near their mouth. The other thing as well, as you can see here with the insulin glucose tube versus the Dex tabs, they're going to have different concentrations. So before you actually give the medications, make sure you're checking the tube. I know a lot of times with the tube, it's nice because usually about 25-ish grams per tube, depending which brand you go with. So usually you're just giving them a full tube. But double check, because again, the same thing with the tabs, especially when we look at giving 12.5 grams to little ones. It's like, do we give them half tabs, full tabs? How much are we giving them? So make sure you reference what it actually says the concentration is in the bottle or the tube and translate into what our care maps say to give. So we gave some glucose and we're going to recheck. And if their hypoglycemia has improved after 3 minutes, we can repeat that dose. And if after another 3 minutes, their blood glucose is nothing's really changed, the blood glucose hasn't changed, we're going to look at, does hypoglycemia persist? So obviously giving oral meds may not always work. We're in shock, our GI system tends to shut down. So if we are taking a lot of oral meds and they're kind of just sitting in their gut and not really being absorbed the way we want them to, or just the fact that our patient is not able to cooperate with us or swallow, because again, they might be combative too. We got to keep that in mind with hypoglycemia. They may not be the most cooperative patients. So if they're not able to swallow, we're worried about aspiration, choking, or they're not cooperating, or we've given a bunch of oral glucose and their sugar's not getting any better. We've got some other therapy options here. So with that, PCPs and up can give dextrose IV as per M06.2. So same indications, contraindications as we had for oral hypoglycemia meds. If they're hypoglycemic, we give it. If they're not, we don't. Pretty straightforward. The big thing to keep in mind with dextrose, it is a high alert medication, so there is weight-based dosing involved. So always check your math. The person that's giving it should check the math. Double check with your partner. Do that closed loop communication. And as a partner, be a good partner. Actually double check the math. Don't just have the person attending going, oh, I'm going to give 100 mLs. And as a partner, you're like, sure, that sounds great. Like actually do the math in your head or use a calculator. Never be scared to use your calculator. Make sure we're doing correct doses, especially when we talk about pediatric patients. So with dextrose here, so we can give it IV or IO. With this here, for 10 years and up, it's 5 mLs per kg of 10% with a max of 250 mLs. So when we look at D10 versus giving D50, 250 mLs, which is the max dose, has the same amount of dextrose. So 25 grams is found in 150 ml ampule of D50. So when it comes to giving these medications, we always want to try D10 first. You give your 250. It's the same thing as giving D50. It's the same dose of actual dextrose. So 72 hours up to 10 years, we give 5 mLs per kg with a max of 100 mLs per dose, and that's for PCPs and up. Now, the big thing is just going back to D50 here. Standard practice is no longer to start with D50. We are going to be giving D10. That is our first line medication. if we're worried that our patient is going to suffer from fluid overload, so let's say, yeah, you also take the lungs, and you already hear crackles in the lungs, we're obviously not going to give them more fluid. We're going to hold off a bit. So we can use D50. Other than that, we want to give D10. When it comes to D50 versus D10, there's more benefits to D10. It's not as concentrated, it's not as hard on the veins. And realistically, if all you can get on your patient is a 22 or a pediatric patient at 24, you can give D10 through that rather easily, just like any other IV fluid, versus trying to push D50 through a 24 gauge IV. It's not going to work. And especially if the vessel ruptures and the D50 leaks out, it's going to cause more tissue necrosis than D10 is. They're both caustic, but D50 is way more caustic than D10. So just to reduce injury to our patients, D10 is preferred. But again, if you're thinking your patient cannot handle more fluid, you already gave them bolus because they're hypotensive as well. You got lots of crackling, and yeah, then you can give D50. Big thing to note though is we never give D50 to children. It's actually very dangerous for them. It can cause cerebral edema and neurological injuries. So once you start getting under 10, do not give D50. Okay, so it's adults only for that one. So technically 17 and up is D50. So you can repeat the dose every 5-10 minutes as required until your blood glucose returns to normal range. Again, if you give one dose of D10, the nice thing is with the 500 ml bags, you give half a bag, that's 250. You give the other half, that's your full bag, so that's 2 doses. If you're getting to switching bags and giving 3 or 4 doses of D10 and it's not raising the blood sugar, then we got to be suspicious something else might be going on, and like such as insulin overdose, or just maybe this is just not a therapy that's going to work for this patient. So if dextrose isn't working for you, or you can't get your IV, which is very possible, and they may not be bad enough that you can get, you figure you need to do an IO, because if you've ever seen someone it's conscious get fluid pushed through an IO, it is not comfortable. So you're not quite ready to go down the IO route. EMRs and above have glucagon as an option. So with glucagon, we're going to be introducing a new nasal powder. The glucagon we have in the vials is not going to be available to us in the near future, so we had to figure out a different different method to get glucagon into our patients. So because of this, oral glucose and glucagon is all from EMR level and up to administer to patients. So with this, again, EMR for indications, it's confirmed hypoglycemia or suspected, and you've tried oral glucose and it's not working. For PCPs, it's confirmed hypoglycemia and oral glucose is not effective, and you can't get an IV access. So sometimes, again, just putting some gel in their cheek is not working for you. It's not working fast enough, and their blood sugar is not really going where you want it to. You can switch to this nasal powder. And again, contraindications aren't really applicable, because if they're not hypoglycemic, we're not going to be using this. So this one is new. So it's a one-time dose of 3 milligrams for ages 4 and up, and that's it. We don't give it again, one and done. So this is the Baqsimi single-use intranasal glucagon device. Inside it has 3 milligrams of nasal powder. So before we were giving 1 milligram through the former glucagon. So this one is 3 milligrams of glucagon in an intranasal device. So it comes wrapped up like this. It's just a single-use device, and we do not open it. Don't take off the shrink wrap or anything until it's ready to use, and just make sure it's stored at room temperature. So just like any other med, we want to make sure it's not expired. So it has right on the side there the expiration date. So we want to make sure that it is not expired before we give it. The next thing to do to open it up, so it has on the shrink wrap at the top, it has a red tab. So we take that red tab and we pull it down, and that should take the shrink wrap off. So inside is the actual device. So on the tube, we open up the lid and take the device out. So inside, you remove the intranasal device from the actual tube. So the idea is you hold the device between your fingers and your thumb. Be very careful not to push the plunger down, because there's only one dose in there. If you accidentally fire it off, you don't get another shot at it. You're going to have to use another device. So with that there, as you can see, you insert the tip of the device gently into the nostril until your fingers touch the outside of the nose. So as you can see, there's the 2 fingers on the top, one on the bottom with your thumb, and then you insert it till your fingers are actually touching their nostril. So that's the depth you want to go. Once it's in there, just straight up push the plunger down. So just push it all the way in until the green line disappears, and then you're done. That's it. When it comes to intranasal medication administration, some people have different opinions on it, but it's actually been shown in research that when we give intranasal medications, we don't want our patient to breathe in deeply. Because I've had some people saying that they like to give intranasal. When they do, they get their patients to go and take a big nasal breath in. That actually is counterproductive, because if they're inhaling forcefully when you give an intranasal med, they're actually going to inhale the medication. We want it to go into the nasal cavity and get absorbed. So if you're inhaling, it's probably going to bypass where it's going to absorb. So just get your patient to breathe normally and just spray up their nose. And just a side note in general with glucagon here is that it is based on your glycogen stores. So if you have someone's very emaciated, kids that are dehydrated, haven't been feeding as well, glucagon may not work for them, because if you got someone that's got poor nutrition, malnutrition, they just don't have those fat stores. Or even on the flip side, a very healthy athletic individual, they may not have the fat stores, glycogen stores for this to actually work. But if it's better than nothing, give it a try and see if it works, if you can't get IV access and oral medication isn't working for you. If you find after you've given this, because it is one-time dose of that 3 milligrams, and it's not working in the ways you'd like it to, then this is something you would give while you're still trying to get your IV access. And then just going back to the care map here, if you've given oral glucose as an option, you can't get an IV, glucagon is not working for you, then you can look at using IO for D10. And then the dosing doesn't change when you give D10 through the IO. You can give D50 through the IO if you need to. The dosing is exactly the same. One side note as well, it says ICP dextrose IO. So ICPs can initiate IOs, PCPs are not. It's not in your scope of work. But when it comes to so if an ICP has started an IO, a PCP can give a medication through an IO. PCPs are just not allowed to initiate an IO. So something to keep in mind there in case you have an IO that's in there already. If the hypoglycemia is resolved, we keep on reassessing blood sugar every 30 minutes or so, because you can get rebound hypoglycemia where you've loaded the patient up with oral glucose, glucagon, D10, they're all loaded up. And so the body actually stops producing its own, stops taking care of itself. So you might actually get a drop afterwards because you've given all this sugar to this patient. So we always want to be watching for that drop. Just constant reassessment. And again, same thing if it's an insulin overdose or medication error, we might be looking at giving excessively more amounts of these medications. So constantly reassess these patients. It's not just, oh, we gave you some glucagon, you're good to go, sign a refusal, see you later. We want to make sure we're checking them over a period of time just to make sure that they don't have that another hypoglycemic episode before we leave. And that's a whole review. So thank you for sitting in. Just a very quick look at some of the changes we're making that coming on June 1st. I don't have a specific date on where we're going to have the Baqsimi intranasals, but as our vials of glucagon start running out, we will be slowly switching over to that device. Any questions? All right. Thank you very much and have a good day.